Hi, everybody. This is Abnormal Psychology, and we're talking today about panic disorder. And the first thing that I want to talk about is, uh, on this part one, is to talk about the difference between normal and abnormal anxiety. Okay? So, the word panic itself just means an extreme anxious response. A panic attack is something different. Okay? But when someone has a strong urge for self preservation and reacts with their sympathetic nervous system, their heart pounds, their digestion stops, they begin to scan the environment with hypervigilance, then what we know is that the urge to preserve oneself to survive is extraordinarily high at that moment. And in the face of danger, that's not abnormal. That's not abnormal. So, first of all, the reaction that people have in the face of danger has a strong physiological as well as emotional component set. Panic reactions are largely involuntary and are initially mostly outside of our control. Mostly. Okay? A panic attack is a relatively short period of time, 10, 20 minutes most, wherein there is intense anxiety and intense discomfort that reaches a peak very quickly. And in order to call it a panic attack, it has to have at least four associated symptoms. There's a list of 13. I want to just give you a few of the more common ones. One is that palpitations, pounding heart, accelerated heart rate. That's the most common thing. Trembling, shaking, sweating, shortness of breath, maybe even a sensation of smothering. Can't get a breath. Chest pain or discomfort, which is the thing that causes people to uh, believe that they're having a heart attack and go to the emergency room. You could also feel dizzy or unsteady. You could have numbness or tingling. Paresthesias is what we call those. Fear of dying. There are also that's the majority of the most common symptoms. Okay. Now, sometimes you will have, and usually you do have, what's called anticipatory anxiety. Because a panic attack is so significant in its symptoms and so uncomfortable and unsettling, what you tend to do is to anticipate another one coming. I'm going to get out of the way of that television that's behind me. And in fact, when you are in whatever place you're in when you have the panic attack, you will associate immediately a cause and effect relationship. So you will not want to repeat that panic attack, and you will think, well, I had it when I was driving down the highway, so now you're not going to drive down the highway. And over time, what happens is they develop a number of phobias. Okay? Because they have panic attacks in different situations. Yeah. So panic attacks that are cued by real danger, if they really have that many symptoms to call them a panic attack, really, panic itself is not pathological. It has too much of a good set of outcomes for saving your life. It's the uncued ones, the ones that are associated with no danger, that come out of the blue, that begin to get really problematic. Okay, so you could have a panic response, even a panic attack, with things like social anxiety disorder, which we haven't covered yet, or a phobia, but that doesn't mean it's panic disorder. Okay, and then you have another symptom which is typical, and that is you try to avoid them. You'll do whatever you can to avoid them. So people will self-medicate with nervous system depressants like the anxiolytics, the anti-anxiety medications, for example, or alcohol, very common. Okay? All right, that's the basics. Now, you can have either mild, moderate, or severe as in all disorders. And so a mild form refers to maybe 1 or 2 panic attacks per month. A moderate's about once per week, and severe would be up to hourly. Can you imagine what that would be like? If you've ever seen someone have a panic attack when you have not had one, you can tell how awful it is. Having them hourly, more than once an hour, oh my goodness, that's disabling. That's disabling. Now, the intensity of panic attacks varies from person to person, from mild to transient symptoms to more prolonged events with high numbers of symptoms that are very intense. Again, they don't last all that long while you're in them. They can feel like forever. But generally, they don't go much more than 15 or 20 minutes before they begin to calm down. And that's a very important point to make in terms of treatment. Okay? Prevalence is, around 3% of the U.S. population, 5% lifetime prevalence, something like that. They typically develop, this disorder typically develops in later adolescence or early adulthood. Women are twice as likely as men to develop this, and only about a third receive treatment. A lot of people with panic disorder end up with the ER, and then when they describe chest pain, they wire them up with an EKG and see that they haven't had a heart attack or check the enzymes. No. And then they'll call in a psych person to talk with them. A lot of them end up in the ER. So I have a video that is hyperlinked in your PowerPoint. It is a Southern Asian gentleman who is on an airplane and he's having a panic attack, and they're trying to keep him calm. They're also, which doesn't work, they're also trying to keep him from doing something foolish, like opening a door or something. So there's a number of people around him. And I want you to be reminded that when we see clips, when you watch these clips, that you don't want to make fun of people. This is not appropriate. And we want to be empathic instead and know that these folks are in terrible discomfort and pain, and leave it there, okay? All right. So there are unexpected panic attacks, as I mentioned. They come out of the blue, they're uncued, there's no discernible reason for their existence. And we also have situational panic attacks where you always have a panic attack in a particular place, like entering a tunnel or crossing a bridge or something. That can happen. It's a little bit unusual, but that can happen. Then we have situation predisposed, which is where you're likely to have a panic attack, but you don't always have a panic attack. Okay, so this is a continuum from one end to the other. The overall treatment is to help them get control over their anxiety symptoms and create greater predictability. Okay, so we're in treatment, which we'll talk about later, involves both of those objectives. If you don't treat this disorder, it has a fairly consistent outcome. One is that it results in depression, which is what many of these disorders that we talk about in this course end up with. They frequently, as I mentioned, generate phobias, and there's a big risk for drug and alcohol abuse in self-medicating the anxiety. Okay, there are some risk factors we know exist. One is temperament, so we have what's called negative affectivity. That's a neuroticism, essentially, worrying about the world. That their anxiety is sensitive. They're sensitive to their own body sensations. And just noticing what they think might be an anxiety sensation ramps things up, okay? People who have had limited symptom attacks, which means fewer than 4 on the list of those many, in the past, are at an increased risk for developing full panic disorder. And having separation anxiety disorder as a child can ramp it up too, the risk. So environmental factors include childhood physical and sexual abuse, smoking in the environment, not just them, but anyone in the environment, and lots of stress in their environment, living in an unsafe place, whatever that may mean. And then among the genetic and physiological risk factors, we see that multiple genes confer the vulnerability, but we don't have a handle on it precisely what those are. There may be amygdala malfunctions within the limbic system, family histories of anxiety, depression, bipolar disorder, respiratory problems, asthma, things like this, can confer additional risk. Okay? A number of medical conditions can create vulnerability, can actually cause panic disorder. Mitral valve prolapse, which is a very minor cardiac leakage problem. One of the valves is leaking. Hyperthyroidism, hypoglycemia, medication withdrawal, adrenal tumors, what are sometimes what are called pheochromocytomas. Of course, Freud had great explanations for this, which don't turn out to be very true. Unacceptable conscious conflicts blocked by the ego, powerful enough to produce constant tension, and there's a breakthrough, and those are the panic attacks. That's a simplified understanding. Okay, now what about treatments? Well, the treatment of choice is cognitive behavior therapy. All of the anxiety disorders are best treated using cognitive behavior therapy. We have a lot of good evidence that suggests that directly. It's generally viewed as the most effective form of treatment for panic attacks and panic disorder. And it focuses on not just the behavior, but also the thinking, the cognitive behavior, thinking and behavior, okay? And there's even a subcategory of cognitive behavior therapy for people with this disorder called panic therapy. Panic control therapy, excuse me. And this is available in workbooks, but it's probably best for anyone having moderate to severe panic disorder to seek the help of someone who knows how to conduct that kind of therapy in particular. Part of what helps people reduce their ultimate collection of symptomatology would be something called exposure or exposure therapy. So part of the treatment, no matter what kind of cognitive behavioral offshoot you might use, you have to consider using exposure. So what we want to do is help people get used to the symptoms that they might experience. So for example, in a therapy session, they might breathe through a straw to get the sensation of limited oxygen supply. Or be asked to hyperventilate or something like that, or turn around in a circle to get a little bit dizzy. And with each exposure and then relaxation techniques, which you would teach them initially, they become less afraid of the internal body sensations and feel more control over things. That's an example of how you would do an exposure portion of the therapy. So what are these relaxation techniques that we would use? Well, we'd use progressive muscle relaxation, where you isolate certain muscle groups and tighten them, hold them for 10, count of 10, and then release slowly, and then go through your entire body doing that. And it really does work wonders. It's amazing how that works. Deep breathing, a particular kind of deep breathing, thought stopping, guided imagery, exercise, and doing instead of thinking. Doing instead of thinking. Now, medications can be useful in moderate to severe forms of this disorder, but we must be very, very careful about what we use. So we don't want to use barbiturates, which were used traditionally in the 50s and 60s. You don't want to do that. Terribly addictive, and the withdrawal is dangerous from those medications. Benzodiazepines like Xanax, only for a very short period of time. You don't want to be on that for more than, say, 2 or 3 weeks at the most. Now, what they'll often try you out on is a SSRI, selective serotonin reuptake inhibitor, like Prozac or Zoloft or Paxil is another one that's often used. This can address both anxiety and depression if there has been depression that has developed as a result of this disorder. Some TCAs tricyclic antidepressants, like anafranil, which is clomipramine, generic, um, are sometimes used as well. But the SSRIs and the SSNRIs, which are mixed neurotransmitter medications, SSNRI stands for selective serotonin and norepinephrine reuptake inhibitors. So that's a look at panic disorder. See you next.